Good morning, everybody. It's great to be here and was able to fly over all the bad weather, so that was one advantage of coming all the way across the country. I'm going to take kind of a step back up and talk a little bit in broad terms around what we're trying to do in the state of Oregon. We're trying to do a whole system change, and we recently had a certified smart person come and consult with us in our governor's office, and one of the first things he said is, I think you should pick a few demonstrated proof of concept models and try them out on a small scale. And everybody kind of looked at this guy and said, you haven't read anything, have you, about Oregon? Because what we're trying to do is to start from the bottom up and involve all of our systems. Our vision is to bring everybody under the tent, to set high standards, to measure them and report them out completely transparently, to unify our purchasing power, excuse me, and to pay with a global budget. To Josh's point, really changes the dynamics of how people think about, how am I going to make money here? Because the old way of making money is not going to get me anywhere. We're trying to stimulate system improvement and innovation, and we're trying to do that through withholds and incentive funds, and I'll talk a little bit about where that is. We're trying to ensure health equity for all, and that's been built into all of our metrics. And we're trying to train a new health workforce, not only navigators and promotors, to integrate them from the community into the teams, across those bridges of where you're getting your care, but also really work to help licensed personnel that have been trained in different ways to figure out how to work in teams, to understand who they can count on. So this first framework, I'd like to thank TIFA and the California Endowment and the Kresge Foundation for pulling this together in a couple of venues that we were talking to each other around. And it's been very useful in Oregon to talk to stakeholders across systems. So we're trying to do the triple aim, and we're trying to do it coordinated, and we're trying to integrate it across community efforts as well as public health and primary care. Next slide, please. So we have these domains, if you will. We're trying to make sure that mental health, dental health, alcohol and drug, and hospitals and specialists are all held to accountable outcomes together. We're a state of about 3.8 million people. We have 670,000 people on Medicaid and CHIP. The Affordable Care Act will bring in another 200,000 people. And our public employees, who are commercially insured, of course, represent 130,000 more, and our Oregon Educators Board insurance covers another 120,000. So we really have a tipping point. Basically, 1 in 7 people in the state of Oregon that have commercial insurance are covered by some sort of public payer, whether it's the library system, the school system, the health department where I work, or other places. So we have, an alignment of really a critical mass in the state. We have several other initiatives. One, of course, is the Oregon Exchange, which will start enrolling in October 1st, I believe, for our January deadline. And also, we have another big initiative going on called the Early Learning Council, which is looking at 0 to 5-year-olds across the spectrum of education, social service supports, and a variety of sectors, getting aligned outcomes and interventions around that. So if we start with a Medicaid population and moving it up into implementation of the Affordable Care Act and the commercial market, why would we do that? Well, you saw some of our numbers, but also one of our CEOs of a 5-hospital system, one of our largest in the state, said, and he's also the chair of our largest coordinated care organization, if we can demonstrate by working together across these sectors that we can change our models of care, that we will work along the continuation of interventions for a healthier population, you can bet your bottom dollar and be assured we'll employ those same models of care and change the way we deliver system, regardless of the patient's payer. So the next slide just looks at the state of Oregon and shows that we've organized this coordinated care organization service area across the entire state and have participation across the state. The Action Plan for Health is the thing that we're using that was put together by the Oregon Policy Board in 2011. It's what we're using as a template to align activities. And we're also, in addition to the triple aim, we've started circulating to have a conversation together across the state, this concept of a collective impact. What does that mean? And you know that that comes out of Mark Kramer and John Kenya's work. But just having a conversation, which we thought was so powerful, organizing around the triple aim language, let's continue that conversation to get it into a more community-based understanding. So we're talking to each other about collective impact. Next slide, please. So our commitment to CMS up here is really, success is benefiting us all, we believe. We do believe that we have to be completely transparent. We just posted our first benchmarks across all the system indicators on the website. So the truth will set you free, and it will be out there for all to see. Our accountability is resting in this metrics and scoring committee, and we have looked at the idea of, well, how do you make sure with different payers and incentives, and even though we're all holding hands right now and collaborating, you know, how do you keep everybody at the table? And the Oregon put in statute the metrics and scoring committee, so that regardless of which administration is in or out, it's now a state statute. And these are the elements which are up here on your screen. And the whole committee work was really a several-year process, and we had over 78 public meetings and got one set of metrics out of that, as well as our working plan. Next slide, please. So what are we doing around CCO incentive measures? And can I, let's see, can I try this? No. So I had, not as fancy as you, Josh, but I did have a very fancy thing where the intersections with public health would come up in red if you pressed the slide, but I guess that's not working here. No. Okay. Well, I apologize for that. But what we did was looking at our planning effort across all of our core metrics. What are the major metrics that public health can have a real influence on and a defining influence? So our annual assessment is 17 measures. We'll compare that performance. And we actually have a quality pool funds available based on that performance. And that is a withhold of up to 2% of their global budget in the first year. So you get that money put back in if you, as a coordinated care organization, across all of your activities are able to demonstrate that you've met your metrics. Okay, let's see. The quality improvement focus areas that we have everybody organized around: improving behavioral and physical health coordination, and indeed demonstrated integration for outcomes, prenatal and maternity care. And these are, if we went through this with our red, you'd see that public health has major influence on how we define and account for improving prenatal and maternity care, how we integrate behavioral and physical health coordination. And to the point that Josh made in his last presentation, a story about the emergency medical services and the first responders and how we need to integrate our incentives around that. This is one of splitting those costs so that the hospital is not penalized, nor is the ambulance system penalized for not taking the transport, but that we split the difference. And in the end, when we meet our goals around readmission, et cetera, and better care in the behavioral health metrics, we'll have that money that will be split across the entire system. Ensuring appropriate care is delivered in appropriate settings. A lot of the work around having the promotores work with that and the navigators across systems, not just identified for one clinic or one area, but for a community understanding of who's going where and how we're trying to get appropriate care at the right level. And then public health, of course, is defining how we're addressing our discrete health issues such as asthma, diabetes, and blood pressure. The next slide, please. Okay. So what are our best practices to manage our coordinated care? We took 6 areas here, and we're trying to identify all of our metrics under them. And where public health has a role in influencing them, we're identifying discrete public health population measures and activities from our best practices and from public health, the CDC's preventive task force recommendations, et cetera. So first of all, under best practices to manage and coordinate care, let's see if this will work. So the plans for prevention and this is working now, yay team. The plans for prevention and wellness, including addressing disparities. Public health has a major role in making sure that not only we're at the table, but we hold that metric, and we define success in that. And then the broad adoption and use of electronic health records. We're lucky in that our systems in Oregon are almost all in the same electronic health record, and we have an ability to talk between systems. However, making sure all of our federally qualified health centers through a consortium are engaged in the same metrics and in the same electronic health record. Is something that we've been working on for a couple of years now. But also, how does public health put into statute, what are the reporting requirements that it needs to determine if a community is doing better and not just individuals in a certain health system are doing better? So in addition to best practices to manage and coordinated care, we've organized around sharing responsibility for health and measuring performance. And again, under measuring performance, we see as the key place for public health intervention. Demonstrated understanding of the population served, quality and cost access measures, and of course, strategies for targets and improvements. And one of the things that's happened across the state at these coordinated care tables is that we've kind of stopped shouting at each other. You know, public health thinks if it just talks louder and louder, you know, like when I'm in a country where I don't speak the language, I think if I just say what I need louder, someone will figure it out instead of stepping back and saying, maybe I need to learn some new words here to get what I need. We've kind of been able to really understand each other much better. And as I say, I've developed enormous compassion for hospitals and health systems because they are forced in this new world of having to figure out how to be accountable to their boards and their nonprofit mission, as well as make money in a way that this is not the way they've been taught how to make money. So we have something to offer them, but having the conversation together has made a huge difference. Paying for outcomes, payment is aligned not with outcomes now and not volume. That gets to the global budget. We've included incentives for prevention and improved care of chronic illness, not only from the Federal Affordable Care Act perspective, but specifically around looking at the epidemiology in certain communities and identifying priorities for that community. Public health has a lot to contribute to particularly understanding cost and quality in the interface between cost and quality in a way that our traditional providers haven't necessarily looked at it. And I want to just, at the end, just talk about, well, what would this mean? What do all these kind of fancy things mean on the ground? If you look at diabetes, which is a priority in the Affordable Care Act, it's also a priority in our state, it's a priority in my jurisdiction. This is kind of how the population spreads out, how many adults we have, how many adults that are at risk for diabetes, how many adults are diagnosed with diabetes. And BRFIS is a source of a lot of this information. And then with those people with diabetes, how many of them are privately insured, and how many of them get care, how many are already on the Oregon Health Plan, and how many in the Oregon Health Plan are getting care. And then we also have a commitment to rolling in all the uninsured into our metrics as well as our service outcomes. So if we look at that across in my county, we look at what is each of these areas doing? What is the role? So under primary prevention for my population in general and my high-risk population for diabetes, we tell the story of what it is that public health is doing. We're doing, obviously, health education efforts. We have our Healthy Retail Initiative. We have our school-based healthy eating, our safe routes to school. And then at the policy level, we do a lot of health impact assessments in a variety of areas, building new bridges, new low-income housing, tearing things down. And we also have a policy through the state as well as the city of Portland and Multnomah County, which is the jurisdiction that the city of Portland is in, that health is considered in built environment decisions, and very specifically around sustainability issues, with a very strong emphasis on equity. And then for secondary prevention, for those who are at high risk and maybe those who are already diagnosed, we look at all of the work that we do around health education, health screening, community policy levels. And then the role for our system of care on the individual level. This isn't new for anybody, but to have the narrative reframed so that people can see that all of these are elements that we need to pay for in our system, our transformation system, to be able to actually make a difference, to have a healthy community for all Oregonians. So back, thanks to my colleagues and collaborators, we're taking things like the top 10 causes of morbidity and mortality. And here in Multnomah County, tied for 9th, is liver disease, end-stage liver disease. And those of us who are clinicians know how incredibly resource-intensive that is, and to take care of it. And that there are two major behavioral factors going on for end-stage liver disease. One is hepatitis, and one is alcoholism. And how can we map this map to treat that in our community? And there's a place for payment. There's a place for the Community Prevention Guide, has many policy options around here, from making sure that you can't sell liquor after a certain time at night to making sure you can't sell wine shots. There's 3 pages in the Community Prevention Guide of policy for public health around that. But there's also what we don't think all the time are the payers and the insurers. And now that we're going to have expansion of coverage, we use the example that many payers don't pay, for instance, for hepatitis C treatment. It's very expensive, it's a long course of treatment, and there's a lot of social negativity around people who may be at risk for that disease. But if we can explain to them, they're not going to change anymore. They're not going to churn off. Now they're yours. And if you're not going to pay for giving the intensive, expensive IV drug treatment up front while people are ambulatory and still working, you're going to be paying for their liver transplant down the road. And there's like this, we really are all in this together. The social determinants of income, community, and family environment, working with community-based organizations around having them identify across those primary, secondary, what is it your work here to change the dynamic. And then we just got a new governor's charge for the Health Policy Board, June 3rd, to create an environment for a commercial marketplace in Oregon that's characterized by our models of coordinated care and a growth rate of total health care expenditures that are reasonable and predictive. And I think that the challenge that we look at as merging in whole care is back to Dr. George Brown, the head of the legacy system. We know that if we can bring these costs down and get better outcomes, as we said to our legislature, who was beginning to panic about the fact that we were going to bring possibly between the exchange and Medicaid expansion 400,000 more Oregonians on that we're going to be responsible for paying. We said, well, approximately 30% of the care people get is not needed. So our challenge is to make sure that those people coming on don't just get that extra 30% of care, but that we all work together to make sure everybody gets appropriate care and that we're all getting that 70% of care. So that's, thank you. Thank you. I have in the packets I have a lot more detail on the action plan for health and how we're measuring our progress across every one of those measures, and how we're trying to integrate the other sectors into the outcome measures. So, thank you.